Yeah, I don't usually start the recording until right when I start, so we don't end up with a lot of ambient activity. Anyway, well, good morning and welcome to EQIP. We hopefully will have a relatively short meeting and give you a little bit of time back. Obviously, the most important thing maybe to take away from the meeting is that open enrollment for 2023 is happening now. So if you missed an email and didn't notice that, yep, if you can mute yourself if you're not on, that would be very helpful. If you're not speaking again, but nonetheless, open enrollment for EQIP is happening now. So we've talked ad nauseum, and I think we'll talk a little more today about the new practices that are eligible and the new codes that are eligible. I think we're going to go through that a little later on, but I think the most important takeaway is that you should be focused on that and think about which physicians you want to add if you're already in and you're already an EQIP entity. And if you're not already in, you might want to think about encouraging folks who are not to go ahead and join. And again, for those of you who don't recall, or for those of you who are watching this on video later on, it's ophthalmology, allergy, dermatology, urology that are being added. And we have more codes available for the original three specialties: GI, ortho, and cardiology. Obviously, neurosurgery and some of the others meet some of those codes as well. So make sure you take a look at that. We really want to have a strong engagement on this. And this program is not just important for physicians. It's really important for the entire system. One of the things that CMMI really wants to see is alignment and community engagement. And the great thing about the EQIP program is it really is the definition of alignment. We couldn't be doing it without the help of the University of Maryland as the administrative entity. We have hospitals working with private practices who are involved in this. We also have hospital-based practices who are involved in this. It really is cutting across all the different aspects of the healthcare system in Maryland. So it's going to be a really important thing that we mention when we're talking to CMMI about extending or changing or moving forward with the waiver. So I just really think that it's important to think about not just the value of the program to the individual practice, but the value of the program from an alignment point of view to the goals of the total cost of care contract and moving forward. So sometimes it's important to remember why we're doing things. We get into these modes where we just put our head down and get our work done. So having said that, I'm going to turn it over to Jessica to start with the meat of the meeting. And like I said, we're really hoping to get you out of here in a reasonable time this morning. So Jessica, it's all yours.
Thanks, Jean. So as you mentioned, we do have a relatively short agenda for today. We'll just talk over sort of the administrative and enrollment updates. Then I'll hand it over to Will from the HSCRC, and we'll discuss the final policy regarding chronic conditions. And then we have gotten some questions about the performance data for PY1, so we'll review the schedule and release of that as well. So as you mentioned, we are open. So EQIP is open. Enrollment needs to be completed prior to Friday, September 2nd for participation in 2023. Really the main reason for this deadline is we have to submit all these NPIs to begin the CMMI vetting process. And that's really why we have sort of this short window. Contracting will begin after we get initial vetting results back. And just as a reminder, care partners who, although we use the baseline of 2019, care partners who were not practicing in 2019 may still be included in the performance year 2 rosters, as long as the entity in its entirety meets its eligibility thresholds, which I will remind you guys about in a few seconds. Also within the EQIP portal, when you guys are completing enrollment, there is some initial baseline data to determine your eligibility. So those episode thresholds, as well as determining your participation opportunity, such as your tiered shared savings. We do want to make a reminder that these numbers are not considered your final target pricing, as that is determined after we get your final lists in and we are able to run all of the audits that are needed. So as a reminder, the enrollment process, I believe all of our existing admin proxies and care partners did receive an email, but just as a reminder, there is a new training that was put up on the CRISP website. Honestly, it's quite similar to last year. There were some tweaks to the portal, but it should look fairly familiar. For our existing entities who are just looking to make changes, a care partner or an admin proxy can go into EQIP and make those changes for enrollment, such as editing their care partner lists, changing or adding episodes or interventions, if they need to update where their payment remission is going. All of that can be done when they log into EQIP and select the start enrollment process. We also wanted to make this a little bit easier, and your information from performance year 1 has been pre-populated into the portal, which allows those individuals just to hopefully make those edits and tweaks as needed. That being said, for brand new entities, so this could be let's say a group that is practicing right now but wants to split into 2, or a completely brand new group with one of the specialties that Jean mentioned earlier. The process does have to be initiated by a lead care partner. After the lead care partner goes in and does some initial enrollment responsibilities, they can elect to delegate an administrative proxy that can continue with the enrollment. Brand new care partners should email that equip@crisphealth.org to set you guys up for the appropriate access. And again, this training can be found on the CRISP website right here, but I can also drop that in the chat after I finish my couple slides. So a reminder about enrollment thresholds. So the volume threshold, so we talked about this a lot in sort of the EQIP 101, but for an entity, when they are selecting an individual episode, there must be 11 episodes in the baseline period, so that's calendar year 2019, in the entity in its whole. So if you have one individual NPI, one individual practitioner, they must meet that 11, or if you have 10, again, in its totality, all 11 or all 10 must meet that 11 threshold. Picked the wrong numbers to compare there. And then in its entirety across all of your episode selections, there must be 50 episodes in the baseline. So again, that could be make up just one single episode, or if you're doing 12 episodes, the total must meet at least 50. The claim threshold. So this was a little bit about what I talked about, how we do recognize that there are new providers that have joined your practices that were not participating in calendar year 2019. So we have this claim threshold of 75%. And what that means is that 75% of all of the NPIs listed in your entity must touch at least one claim in the baseline period. And we say claim because that does not mean they need to be a triggering provider. You could have an advanced care practitioner, an NP or PA that also is enrolled in EQIP that are touching maybe some of the other relevant costs associated in the episode, but not a triggering provider. That counts to that 75%. As a reminder, for care partners who do not touch a claim in the baseline, again, can participate in performance year 2, but are considered on probation and must touch a claim within performance year 2 to be eligible performance year 3. You all should have received those sort of probationary NPIs that are on that for performance year 1 that must touch a claim this year in order to be eligible for performance year 2 as well. These are the episodes, as Jean mentioned. This is the total list. So we have sort of the new specialists that we added: allergy, dermatology, ophthalmology, neurology. And then we have cardiology, GI, and ortho from last year, including some new episodes that can be added onto those specialties. And then we worked very hard and appreciate all the work with our ED physicians. And there's the list of their episodes that they can participate in as well. Okay, so a final reminder of what all those timeline and dates mean. So the big one was last week, I guess maybe it's 2 weeks ago now, but on July 5th, EQIP did open for enrollment. There are the technical policy guide, including the playbook is available, as well as individuals being able to see the baseline episode experience within EQIP. September 2nd, that very big date, we'll send lots of emails to remind you, but EQIP does close for performance year 2. Again, that's that deadline for that NPI submission, and we begin the CMS vetting process. We will go a little bit more into detail, but in October, you would expect the first performance year 1 quarterly data that's available within EQIP. And then also probably mid to late October, hopefully no later than that, we will get the initial vetting results back from CMS. Again, that status will be available for you to view in EQIP, and we will begin the contracting process. And then finally, at the end of this year, December 30th, actually probably December 31st, I'll update that, is the care partner arrangement deadline, and when your final status is determined. Moving into next year, January 1st kicks off the performance year. Again, you will have your target prices, your full baseline data, all of that will be available. We get into the second quarterly update of performance year 1 data, also occurring in January. And then we sort of restart this process all over again. July of next year, we begin performance year 3 enrollment. And then again, middle towards the end of next year, sort of Q3 of 2023 is when we expect incentive payments for those that have earned it in performance year 1 to be distributed. Okay, so I think just as a reminder, that Crisp Learning website, again, I'll plop the URL into the chat for us, does have the some enrollment FAQs, the new training video, the playbook is all available. We want to remind people that while the playbook is comprehensive of trigger codes and some relevant costs, it is really for illustrative purposes, and you actually cannot replicate the EQIP episodes, but it will hopefully direct you guys and answer some of the questions that you guys have about what's included. And finally, you know, HSCRC, Chris, Metkai, Jean is always available to meet one-on-one with interested participants, or if you have specific questions, please contact that email and we'll direct it as needed to the relevant party. So that's all I have about enrollment. Before I hand it over to Will, are there any questions that we have related to enrollment? Okay, great. Will, all you.
Thank you, Jessica. Can you hear me?
Yep.
Wonderful. Okay, next slide, please. So I wanted to spend a little bit of time talking about the chronic conditions episodes that we've added for performance year 2. The reason is these function a little bit differently than our traditional procedure-based episodes. In a procedure-based episode, you know, I think things are relatively simple. A procedure occurs, you're responsible for a given number of days and for the related procedures to that episode. In a chronic episode, these are things like, I've listed them here: asthma, glaucoma, lower back pain, etc., where there's not a clear procedural start to an episode that indicates that this physician is definitively that a physician is definitively responsible for, the managing physician is definitively responsible for. So the way these work is that we're going to assign these episodes to the physician that provides the plurality of the professional E&M services for patients with one of these conditions. And because we're doing an attribution based on the plurality of E&M claims, there's some sort of trickiness that we need to talk about in terms of the attribution algorithm. So if you go to the next slide, please. So these episodes function basically in 3 steps. The first is there's some triggering service that identifies a patient who's eligible for the episode. For instance, I've given an example here. A patient becomes eligible for an episode if they have an inpatient service with a principal diagnosis code related to the episode, or an outpatient or professional E&M service with a diagnosis code in any position. And, you know, I've given the example here with sinusitis, but this would apply for any of the asthma or other glaucoma, etc. In step 2, the episode is assigned to the physician that provides the plurality of the relevant E&M services to the beneficiary. We're going to run this attribution quarterly with a 1-year look back. In other words, at the start of a performance period, a participating physician will have a list of beneficiaries attributed to them for whom they provide the plurality of services in the prior year. And then going forward, each quarter attribution is run again. Beneficiaries can be added to that provider's list of attributed beneficiaries if they provided the plurality of services to that beneficiary. Similarly, beneficiaries can be subtracted from the attributed list to that individual physician if someone else provided the plurality of the E&M services. So unlike the procedure-based episodes where a procedure occurs, the episode is attributed to the physician that performed that procedure, and that episode is definitively assigned to that physician. In the chronic episodes, there's, some churn from quarter to quarter, meaning that new beneficiaries will be added and other beneficiaries will be subtracted based on who is providing the plurality of their services. And I want to highlight this and make sure that everybody is aware before enrolling in those programs. I think it sounds, sort of sensible, right? We want to make sure that the providers are accountable for beneficiaries when they're the provider that is providing the plurality of the care. That seems like a sensible attribution algorithm. But, in every program that we have where we use this sort of attribution algorithm, at the end of the performance period, participants are going to, come to us and say, well, look, I had this person for 9 months out of the year, and then suddenly they disappeared in the final attribution list. What happened? Where did they go? Why don't I get them? And the answer is, that we're running the attribution quarterly. And so some beneficiaries are going to churn. They're going to be added and subtracted from the list each quarter. And I want to highlight that so that people are aware that that's the way the attribution works going into the program. And then the episode will be attributed all relevant costs that occur during the performance year. This, I think, is where the, sort of the rubber meets the road, right? So a beneficiary who's attributed to the provider in the fourth quarter, inherits all of the costs for that beneficiary, even if they were not, attributed them in the first or second quarter. I think our assumption is if you provide the plurality of the care, you inherit, all the costs associated with that beneficiary. And even if that plurality of the care occurs in the fourth quarter. So just want to make sure that everybody's aware of that going in. Next slide, please.
Hey, Will, this is Dr. Grasso. With that attribution algorithm, this will make no sense whatsoever for orthopedic surgeons to participate in the chronic condition bundles. It just makes no sense, because I can't tell you how many times people show up to our offices for knee arthritis with MRIs, which are inappropriate, or low back pain with MRIs that are inappropriate. So we're going to get whacked for studies that are done before we've ever seen the patient. Plus, what happens if I see a patient for osteoarthritis of the knee? They come in with all kinds of studies already done that weren't necessary, and I wind up operating on them during that year. Do they become then a total knee bundle, or do they stay as a chronic arthritis bundle? How do you guys going to handle that stuff?
Yeah, so it's a good question. This is not going to interfere with any of the procedural episodes. So if you're participating in a procedural knee replacement episode, the chronic episodes won't change how that procedural episode works. And so, you're not, if you perform a knee replacement on somebody, you're not responsible for anything other than that knee replacement bundle. You don't have to participate in the chronic episode. If somebody else does a chronic episode for that patient, we deconflict those episodes. And so I think what we've tried to do is make sure that these chronic episodes and the procedure episodes, are deconflicted to the greatest extent possible. With regard to the chronic episodes, I think, there is just, we will attribute the cost to the provider that provides the plurality of the services to that beneficiary, under the assumption that they are most responsible for managing that beneficiary. And I think that's, sort of sensible, right? The person that sees the patient the most is likely to be the most responsible for that patient. There are, because we don't have a clear trigger code that says definitively this patient is, the responsibility of that physician, the way we do with a knee replacement episode. I don't think there's a way to avoid, some issues with churn, right? Where a patient, becomes attributed to the provider in the fourth quarter after they've provided the plurality of the services, and that provider does inherit, sort of the history of that patient. So I guess we want to emphasize this so that people know that going in. I think it's a pretty sensible rule, but I know that there are going to be frustrations and people concerned about, inheriting patients in the fourth quarter, for instance.
Like I said, this may work for primary care providers. it will not work for specialists. So I can't see us or any other orthopedic surgeon participating in a chronic bundle this way. Just doesn't make sense.
Right. Well, so everybody, makes their own decision. I do think that it makes sense for these chronic episodes. I don't think it would work otherwise. But if you want to participate only in the procedural episodes, I think that's a perfectly reasonable decision. Any other questions or comments?
Yeah, I have a question, Will. So if you're attributing based on the plurality of care, you mean for anything, right? Any E&M codes, not just E&M codes for which this diagnosis was the focus.
So it'll
my
be plurality.
scenario. So you have a patient who has diabetes, CHF, and osteoarthritis. I hope they're seeing their primary care physician more than they're seeing somebody that's treating them for the osteoarthritis. So people with multiple chronic conditions, I don't see how they'll ever get attributed to the specialist, because the PCPs should, if we're doing things right, have the plurality of care for those people.
So it's a good question. We still use the relevant E&M definitions that we do for everything else. And so it'll be plurality of the relevant E&M codes, and that's listed in the episode playbook. These are codes that relate to asthma, for instance. And so, a patient that has multiple chronic conditions, we do try to deconflict those. And so, you can be attributed sort of management of that patient's sort of asthma condition.
Okay.
And somebody else could be attributed, a different chronic episode with different related costs. But it's an excellent question. We use the Change Healthcare's definition of related costs. So I would definitely go and take a look at that.
Okay.
There are going to be difficulties, right? So if you have billed a patient for, chronic care management, one of the chronic care management codes, that code doesn't sort of say, this is chronic care management only for, the asthma, for instance, and it's not for one of the other chronic conditions. So, it's going to be impossible to perfectly deconflict those. We do the best we can, and actually we don't do it. We use Change Healthcare, and they have a bunch of docs who do it. But I would take a look at that episode playbook and just make sure you understand what the relevant codes are for that episode.
Okay, thanks.
Hey, Will, it's Jim. And I've missed a couple of months here for this meeting, but are we still looking at the ED codes, and has it kind of been squared away where the responsibility for the emergency department would be? Is that going to be simply those who are discharged from the ED, or does that include those admitted as well? And is that going to come back to, well, it depends on if the admitting doctor or attending is in the program or not, or maybe you're going to get to that. And if you are, I apologize. I'll wait it out.
So we aren't going to get to that here, and I think we covered it in some previous meetings. I'm happy to take, if you have questions specifically on that, happy to chat with you online. We have squared it away, in essence, right? So ED doc sees the patient in the ED with one of the relevant codes, they get attributed that episode. We had some concerns previously about, what happens if they then go to the, get a procedural episode. How do we deconflict that? I think we have a pretty good methodology for doing so, which is basically, the patient for the ED care is attributed to the doc, the procedural episode is attributed to the specialist or whoever performs the specialist procedure. Again, we will have the episode playbook so you can see, the attribution definitions and the relevant codes for that.
Okay, thanks.
Okay, so just a quick reminder, patients are attributed quarterly, attribution will change. We are attributing the patient to the provider that performed the plurality of their care. We think this is the best and most sensible relationship. If you see, excuse me?
Right, Title Health around Salisbury.
Wonderful. So if you perform the plurality of the services, I think you're the most responsible for that patient. There are going to be issues with that. You could be providing the plurality of the care for 9 months, and in the fourth quarter, the patient decides to change doctors and see someone else. If in that fourth quarter they get a lot of services, we are going to attribute that patient to the fourth quarter doc. I think that makes sense, right? You don't want to be responsible for a patient that switches docs and gets a huge run up in costs in the fourth quarter. So I think this is the best rule that we have, but I'm emphasizing this because there will be churn and it will be frustrating. So happy to answer any final questions on this. Okay, wonderful. Back over to you, Jessica.
Okay, so we are discussing performance data timeline. We had discussed this in a prior meeting, but we had been getting some questions, so we just wanted to sort of reiterate this. A lot of this revolves around the whole idea of a completed episode. So episodes are completed 90 days after the post-trigger window, and that's really to allow that claims run out to occur. So of our PY1 episode, just as an example, a 14-day window is actually considered complete 104 days after the trigger. Similarly for 30 days, that's 120 days, 90-day episodes, 190 days after the trigger. And for 180-day episode, that's 270 days after that initial trigger date. On top of this, we have the Prometheus algorithm that Change Healthcare runs, and it runs it quarterly and only on complete episodes. So therefore, episodes, which includes that claim run out, have to be completed by the end of the prior quarter in order to be included in the performance data run. So with that, we have quite a bit of time before we get some full data, and then you would be getting it more regularly on a quarterly basis. So you can see here the breakdown of all of the different episodes and their length. Really in July, while this normally would have been a quarter that we would run data, essentially it would only have caught episodes that were triggered on January 1st or 2nd, which likely did not happen. So our first full data run is actually occurring in October. You can see for our short episodes, so our GI episodes that are 14 days, you actually will get slightly more than a quarter's worth of episodes. For 30-day episodes, you also will get 3 full months. And then for your 90-day episodes, again, because we have that full 90 days plus an additional 90 days of claims run out, you'll get about a month's worth of data. Our 180-day episodes, you will not see the first round of performance data for that until January, but you can kind of see as the quarters continue, you will continue to get sort of 3 months worth of data, depending on the initial episode length. And again, the dates here correspond to the trigger dates, which we feel like that makes a little bit more sense to how you guys are thinking about it. So this colonoscopy includes those colonoscopies that were triggered, so the procedure actually occurred on January 1st through April 16th is what you will first see in the October 22 performance data. As a reminder, your quality metrics are also going to be released at the similar time, because the way that our quality metrics are done, and we have a year look back at the end of the post-trigger window to determine if the appropriate billing codes were completed, and thus you guys got credit for that.
Jessica, it's Dr. Grasso. I understand this completely, and I understand the need for the run out time to have completed data, but I think we're missing the boat here. Why can't the groups that have the capability to analyze the data internally have access to the raw data as it comes in, as near real time as possible? If I have to wait till January of next year to find out who in my group did good in the first 6 months, by the time I make changes, it's a year out. If I had access to real-time data, I have the capability within my group to analyze it and find out who's using SNFs, who's doing things, and make real-time changes now that will have an effect for the rest of the year. I think you're missing out on a lot of potential savings by doing it this way. Why can't we have, I mean, I understand the raw data is going to change. I understand the run out, and we all understand that, but we have the capability to run the data and to analyze it and to make immediate changes. Why can't we have that capability?
Dr. Grasso, I think we're definitely investigating that. There's no, I think, conceptual reason that we can't. We just, we didn't anticipate this, and so we didn't set up the system to be able to do it quickly. So we're investigating changing that and providing incomplete data to participants. I am pretty nervous about it, to be frank. We've done programs where we've provided incomplete data in the past, and it's caused some issues with participants, right? So I'm thinking, Dr. Trumbull, we have had conversations before about some of the data changing from the incomplete data that we provided in the beginning of the program to the final data at the end, and things can switch around, right? You could look really good for 11 months of the program, and then the 12th month where the completion comes in and things flip around, and it can be frustrating to participants.
Yeah,
so I think for that reason,
I fully understand that. I think we're sophisticated enough in this day and age that the larger groups that we know that's a possibility, but we also know the sooner we make an intervention, the more powerful it'll be, the bigger effect it will have. And for me to have to wait an entire year to go to a guy and say, hey, you're still using too many sniffs, what's going on, is a waste. He loses a whole year, state loses a whole year of savings, we all lose. So the sooner we have access to the raw data that we can run our analysis, I think the better off the whole program will be.
Sure. So we're investigating the possibility. We will get back to you. I don't think there's any reason why we can't, other than just we hadn't set up the system to do it. And we can talk about what data we can provide and potential limitations of that once we finish doing our internal work. So I promise you an update next time to talk about that. Providing potentially incomplete data a little bit earlier.
Okay, thank you.
So obviously, as you guys just had that conversation, we do understand that there are implications of this, the lack of timely availability of the data. So we do know that September 2nd deadline, there will be no performance year 1 data available. However, because the timeline is driven by the CMS vetting process, we have to have those participants in by that September 2nd deadline in order for them to be eligible for next year. However, we do recommend, even if you are interested and you're still maybe on the fence, to really complete the application process or enrollment process by September. And then come October, you will get at least some initial, well, not full data, you'll get some initial data, and you'll be able to make some final decisions about the participation. Again, we don't consider anything truly final until that care partner arrangement is signed by the end of December. And that, I guess, determines what EQIP entity you're participating in and which episodes, et cetera. So again, we apologize for just the timing of this. We do know it's not ideal, but we still recommend, at least in our opinion, to at least have that initial submission of I'm interested, I'd like to submit these NPIs for vetting, and then you can have some additional conversations and decisions as the October data comes in.
Yeah, I have Jessica, I have one more question. The one update I did not see in your timeline is, when do we get the updated target prices? When do we get the inflationary factor? When's the inflationary factor announced, and when are we going to see what effect it's going to have on our target prices?
Will, I thought that they were already in, or if Nate's on the line.
Yeah, Jessica, I'd have to go back and check my schedule. So the schedule. So Dr. Grasso will follow up by email with that one.
Okay, thanks, Will.
Sorry about that. Okay, well, if there aren't any other questions, we do just want to remind.
Let's actually go ahead and make sure that on that one, if you could CC me, and I'll send it to the entire list. Okay, because I think a lot of people will be interested in that one. All right.
Yep.
Thanks, Jean. And just as a reminder, we always just point people to that generic email, equip@chrisfelt.org. We'll get it to the right person. We are not meeting in August, but you guys will, I'm sure, get some communication from us about reminders. So our next subgroup meeting will be September 16th. And then, as we've mentioned in some meetings previously, for any people who are interested in creating their own episodes, so these are our non-Prometheus episodes, we really got to start that process sort of around now in order for us to be ready to have it available for the next enrollment cycle. So again, please email or reach out to me.
Since we're not meeting in August. If we wait till September to have the next update on the release of incomplete data, the possibility of release of incomplete, we're almost to the October release point, right? So could we do something sooner than that as far as that goes, as far as the data and releasing raw data to us instead of waiting 2 months?
Yeah, I think, and Will, correct me if I'm wrong, I think as soon as we determine what can be done, we would definitely communicate that out. I don't know if September is reasonable. Will, I don't want to speak for you, but I do agree that we would hopefully have an update prior to September.
Yep. So we'll provide an update as soon as we have a strategy going forward for what will be included in that data.
Okay.
All right, so that's two things we'll send an update out on. And I'll just say to everyone on the call, if there's a big global issue or something you're concerned about, you don't have to wait for the meeting to bring it up. You can reach out to myself or Jessica or Will, and we're happy to try to help out and figure it out. I mean, a lot of you have been on these calls for 3 and 4 years now. So you know a lot about this program and might be seeing problems or issues because of your knowledge. So please, communicate with us and talk to us. We want this to be successful. And questions like the ones Dr. Grasso asked this morning are only helping us make the program work better.
I think that's actually the end of our material for today. So if there aren't any other questions, we can give you guys some time back.
Gift of time.
And I'll send out the slide and we'll try to get the video posted today. So for your colleagues who didn't make it or really want to see this great video, they'll be able to. All right. All right. Thanks, everybody. Have a good one. Have a good weekend. Don't forget to vote on Tuesday if you haven't already.
Thank you.